Much. Hi, everybody. Helen Burstin back again. Thank you so much for joining us. Delighted to have you back for our session on thinking about how we drive adoption and implementation of telehealth. A couple of housekeeping details here. Feel free to continue the conversation on Twitter using hashtag DigitalMed2020. Please use the chat and Q&A feature, ask questions, comments, stay engaged, and look forward to having a great session this morning. As we're pulling up the slides, we've got four remarkable folks with us this morning. Interestingly, who I haven't met any of them in real life, but I feel like I know them because we spent a lot of time together on tweet chats and Twitter talking about telehealth. Again, maybe another interesting example of what happens in the post-pandemic is how much of our interactions and engagement are in fact these virtual experiences. So I'm going to quickly introduce all of them, and then I'll have each of you run through your sessions individually. We'll start with Aditi Joshi, who is the Assistant Professor in the Department of Emergency Medicine at Jefferson, and also the Director of their Telehealth Fellowship and the Medical Director of Jeff Connect. Ritu Thamman is a cardiologist, assistant clinical professor of medicine at University of Pittsburgh, quite the guru of social media in the cardiology and echo space. I always learn a lot from your Twitter posts. Sometimes I don't understand them, but they're beautiful and fascinating pictures of the heart, so I love that. Jorge Rodriguez is a clinical investigator, a hospitalist at Brigham and Women's Hospital, wrote a recent piece exploring the issues of digital equity in particular, where you wanted to bring that equity focus to the table. And last but not least, Chad Ellimoottil is an assistant professor in urology at University of Michigan, and brings as well his degree in economics to the fore as we discuss these important issues around payment and telehealth. So really excited to have a chance to think about what are ideas, how do we leverage and adopt telehealth from lots of different viewpoints. So first, Aditi will give us the viewpoint of what it's been like practicing at Jefferson and running a telehealth service during COVID and lessons learned. Aditi, turning to you.
Thank you. Thanks for the kind words. And I'm about to share my screen. I'm happy to be here this morning. And so, like Helen said, we're going to talk a little bit about how we use and leverage our program of telehealth at our hospital at Thomas Jefferson University. And I have no conflicts. So briefly, I've also been tasked as the first person just to give a brief definition of telehealth. So firstly, what I normally like to do is just talk about the definition of telehealth versus telemedicine. And so here's a very long statement, but basically trying to decipher which are the differences between the two. So telemedicine in general. So when we think about any of the terms, it really just means a remote medical encounter between two parties. Telemedicine more specifically referring to the actual clinical service, where telehealth is more broader and inclusive. And so it also talks about the processes of workflows, a team that's involved, the prevention, maintenance, everything that you would think of that would be part of a telehealth program. And so a lot of times you'll see the words interchangeably, but telehealth is a little bit more broad. When you're defining it, there's two ways to define it that you'll probably read in most of the literature. And the first is by user, and the second is by function. So by user generally means who is actually doing the telehealth visit. So is it between a patient and provider? And most people will think of the direct-to-consumer, the large groups that you have somebody sitting at home calling a doctor or an APP as the first type, patient to provider. The second is provider to provider. And this is what we would also call remote consults. So the programs for the most common ones are probably Telestroke. It's one of the longest ones running, where there is a hub hospital with a specialist and a consulting with a hospital that probably does not have that specialist. And so between the two, it's between the two providers talking to each other while the patient is present. And the specialist can evaluate the patient, determine what to do next. The third type is a variant of the second type, really. It is between the provider and what's called a clinical telepresenter. Clinical telepresenters are a group of people who are trained to do that type of telehealth visit on the side with the patient, but they're not a physician or an advanced practice provider. There are other groups of trained people, usually nurses, techs, or other people who are involved in that type of visit. By function, again, is another way you'll probably see it written, is going to be what is it and how is it being used. So is it synchronous, which is what people consider the video, telephone, is it happening real time? Asynchronous is something that's happening a little bit later. Is it the chat function on like a store and forward where people are filling out or having a question and the provider gets back to them within a certain timeline? And so those are some of the words that you may hear. And so it's usually just to go through it. All right. So I'm going to go through just our experience over at Jefferson. And obviously we were talking about during COVID. And I'm not going to spend a lot of time on this slide, but it's helpful to know that Jefferson had a large program already. It started in 2015. And so we had a direct consumer. We had a bunch of remote consults, scheduled visits of primary care with surgeons. We had critical care consults. We also had some portion of remote monitoring. That wasn't our biggest program at the time when it started. We did some virtual rounds and then also a teletriage program within our emergency department. Because we had that, we also had an administrative department. We had the workflows, processes, and really importantly, we had a bunch of training already created because when we had to scale it, it made a big difference. So just like everywhere else, when COVID hit, and for us in Philadelphia, it was the beginning of March when we started to see some of the changes in our volumes. We had a decrease in scheduled visits. We had a decrease in primary care visits. We had stopped our surgical practices and surgical visits. Our ER had a decrease in visits also. And obviously we saw a change in the visit complaints. A lot more people were concerned about COVID and screening and what to do. And then we had, obviously, just like everywhere, we were figuring out what we were going to do to prepare for this in the case that Philly got hit as badly as New York, which obviously we're very close to New York. And so we did a whole host of different things, which I'm going to go through. And so for our outpatient visits, so the first things we did was leverage our on-demand service. This is what we call Jeff Connect. Jeff Connect is our on-demand program, as well as the name of our platform. And this is what we would consider also the direct-to-consumer, so patient to provider. Most of these are happening where a patient is outpatient and then initiating the visit for us. And ours is staffed specifically by emergency medicine physicians. They're staffed differently around different places, different companies, but that's how we staff ours. And so we noticed a huge uptick. The biggest, we started to notice a drastic increase in patient volume the week of March 9th. And the end of that week, we saw our visits go up about 600-fold. So we had to figure out what to do. And so what we had to accomplish first is get increased staffing, because what we had asked initially was a bunch of ER doctors who were not working, who had been pulled off shifts because our ER volumes were down, to just jump on and see patients. But that was not a way, or we knew that that would not, we would be able to continue that for much longer. So the departments of internal medicine and family practice, and some of the surgical subspecialties who had more time because their clinics were closed, they weren't doing as many surgeries, all offered to help. And so we trained over the weekend of March 14th, 150 doctors. And again, it was helpful because we had training available. And we were able to put it in a module, and we would put and made a bunch of videos so they could do it. And then whenever their first shift was, we would just sit there and watch them and be on call for them. Probably the busiest time I've ever had in my life. I don't recommend training 150 people in 72 hours. It was absolutely terrible, but it was helpful to do that, because then that week of March 16th, and I'm going to show a graph with our uptick, we had enough people staffing it. And so the other things we did is that we used this as a first screening tool for everybody in the southern New Jersey, eastern Pennsylvania region that we cover. And so we were able to send them for outpatient testing. We screened them at home, evaluated whether they needed to come in for a higher level of service, and we're able to expand our services in this manner. This was probably our busiest clinical environment for a few weeks. At the same time, and the reason that we were able to do this and just focus on this, is that our hospital set up a bunch of outpatient testing sites. And it was done very stepwise. There were tents set up at various places around the area. We had a group called Seamless Access that any patient that we put an order in would call them. They would tell them where the testing site was and where to go. And then we had a bunch of people who would call back with the results. This is just a picture of our self-swab squad. They were actually on Ellen, so apparently because they had a TikTok that went viral. So this is just a picture of them, but this is one of our outpatient testing sites. This one actually sits outside Center City in Philadelphia. So this is basically just a graph showing the kind of drastic increase. The 1303 was a week of March 16th, and that was our busiest week to date. We just saw a huge amount of people. And that Monday, we had about 15 doctors staffed to see that volume of patients. At that time, you know, we weren't testing people who just had exposures or were asymptomatic. We had a very strict criteria. So this is who we were testing, and this just shows like where we were able to, how many people were able to test and who were actually ended up positive. Over the time period of March 9th to April 10th, we saw about 6,800 people. I think the year before we saw something like 200. So you can see that it was a huge increase. So next, for our primary and urgent cares, like I mentioned, they had decreased their volume significantly for things that were not acute or didn't need to be seen. So aside from the ones who were seeing on-demand patients, they actually converted a number of their already scheduled visits to telehealth. And they were able to do that because, again, we had a program already set up. And so a lot of them, probably about 50% of their patients were able to be scheduled to telehealth. Some were pushed back, and then some were actually seen on Jeff Connect if they were an urgent visit. Our urgent care started using iPads so that when people would come in, if they had any sign of exposure, they would actually be seen over iPad and screened if they needed to be. But again, our urgent cares also had a very drastic decrease in volume during that time. Most of the time that we saw this, like we didn't have as much testing done in our urgent care at the time. We stopped doing strep tests. I mean, it wasn't flu season, so we weren't really doing flu tests just to decrease, again, the exposure. So we really had to use a lot of like historical documentation or history to figure out what to do with that. All right, so let's move on to emergency department and inpatient. And so again, the emergency department, of course, being the first line. I'm also an ER doctor, so again, I spent a lot of time doing this. But we already had a teletriage project already. So again, we had the software, we had the hardware, we had iPads in our hospitals, in emergency departments. This is what our teletriage computer on wheels looks like outside of COVID. I noticed no one's wearing a mask, but this was before, this picture's from before. But we're able to have a remote medical encounter with a physician or an APP, and then the patients are able to get triaged and orders replaced. Because again, we had a decrease in emergency department visits, we were able to directly bed people, but we had all of this already set up. So what we did is we used it for outside screenings of all the patients who came through the ER. They were seen outside in a tent, determined if they had COVID symptoms and sent to a specific part of our emergency department. Then we use these iPads to triage patients within the emergency department so we could decrease exposure just like everybody else does. And the last thing we did, which made a huge difference as well, is that all of the consults that we needed, we would actually use the iPads as well. Prior to COVID, the psych department had already set up ways to be able to see consults using an iPad. But through a huge interdepartmental collaboration, cardiology, neurosurgery, neurology, and a whole host of other departments also added this on. They did it within the emergency department, but also in inpatient units so that people could get seen on an iPad. And for those who work in academic centers, it was actually done mostly by the attending. So that decreased significantly the amount of time that it took to get people admitted and seen and determine what to do next. I think one great case was like a neurology. Generally, it's about 4 to 6 hours. They get a little bit overburdened. We were able to get people through within 30 minutes, which is incredible. Currently, our ER visits have gone back up and we are boarding significantly. So we have gone back to teletriage. We still use the teleconsults, and we went back to having an outside screening. And so just an overview of some things that we learned using this program. Some of the pros that we had a program to scale. We had the trainings, the education. So when we needed to restaff and do that, we could do this quickly. Being able to do those upscale in 72 hours was because I had trainings there and I had people to help me who already knew what to do. And that made a huge difference. Doing this from zero and scratch would have been much, much more difficult. But this is why we were able to convert thousands of visits. I mean, if you were to, just even that in those 6 weeks of 6,800 patients, that is a tremendous amount of people that we didn't have to see in person. And again, people were able to access healthcare at home. So they were able to get information. What did they need to know? What was, what kind of symptoms did they have that needed to come in? And not even just COVID. There are patients who were afraid to come into the ER, but they had something that could be considered emergent. And we were able to tell them and make them feel a little bit better that say, hey, no, we are doing everything to keep you safe. Here's what we're doing in our ER, please go. And I think that would also make a difference if people didn't stay at home. Some of the barriers, there was a lack of integration. So when we were doing and expanding, it wasn't in our EMR most of the time. So we had to have a number of different platforms open to do that. That is a huge barrier. That is something that was supposed to be fixed during this time, but everything got pushed back because of COVID, obviously. And I'm also putting patients accessing healthcare at home is also a barrier, because we are also pushing back maybe visits that need to be seen. And this is something we don't even know what the effects are going to be long-term. People who weren't getting screening, people who weren't getting seen, maybe there's going to be long-term effects, more chronic disease because of this. We had some unanticipated tech failures. We were able to overcome them. But again, having to plan for that, we didn't really have as much. We had some, that happened a few times. It wasn't too much. And then lacks of access to some groups, right? So our entire program and screening was based on the fact that somebody had a smartphone, had access to connectivity. There were groups of people that did not have that. And we realized this early, especially when we had, our populations around who were vulnerable, who had to come into the ER because that was the only place that they could come. And we found that there was really no way that we could easily scale our on-demand program for that. And that was a big barrier. What they did is they found a grant and got a bus, and they still do this. They run into different neighborhoods for on-site testing, but unfortunately, we still weren't able to do that. But overall, the whole thing was still worth it, and we have still continued this to our day. Thank you for having me. I look forward to any questions at the end, and I'm going to turn it over to our next speaker.
Thank you so much, Aditi. That was wonderful and extraordinary to hear how quickly you could turn, train, and just get that up and running quickly. So next, with sort of more of a view on sort of the effectiveness of telehealth, I'll turn to Ritu. Thanks.
Hello, everyone. Can you hear me?
Yes, there you go. All set.
Thank you so much for that introduction. So my name is Ritu Thamman. I'm a cardiologist, and I will give a physician viewpoint for what the next step looks like since we've gotten through the initial first wave of COVID. Many of you know me from Twitter. I'm the social media editor for both CIRC, CV Outcomes, and for JACE. So what drives adoption of technology? We know that the SARS-CoV-2 has catapulted us into this realm of adoption. And I believe that we are amongst the early majority here. We're not quite over the hump yet, but there are three major factors that are really going to be driving this adoption by physicians. One is operations. How easy is it? Documentation. What do I have to do to make my document compliant? And then third, billing. How am I going to get paid for doing this? So from an operational point of view, it has to be easy. We have to make it easy. And just because we have a device, we may not know just how to make it work properly. This is a screen share of my college roommate's iPhone where she's got 55,000 emails that she still hasn't addressed. She's a star on Broadway. And these are just some examples. One is from the sinks at the hospital, which show this disgusting water. Why is it like that? I don't know. Or train tracks that have two ways going at the same track. It doesn't make sense. So the operational model has to be easy and has to just make sense. And some of the considerations that will drive adoption includes, how do we redesign the workflow so it just flows? And what populations should we really be asking to come back for a telehealth visit? Because if I have a TAVR patient who's frail and doesn't really know how to use the technology, will I be able to incorporate them into a visit? We have to retrain staff because they need to do preparation work. Even when we're doing video visits, they've got to prepare the patients, make sure they can actually log on if there's an app to download, if to reconcile their medications. And as we move into remote patient monitoring more and more, those also have to be coordinated with the staff that's already there. And after we actually see and we identify that the patient's going to be seen, they've got to be educated both on the technology piece and then what do they need to do before and afterhand. There's standardizations that have yet to be fully established. Now, the AAMC has just put out how to do a trainee standard, but it's still in its infancy. And then scheduling, how do we schedule so everyone is on board in the same way? And I love this cartoon. What if we don't change at all and something magical just happens? But that's not going to be the case here. And as a physician, if I look at this engine, I don't want to see what's underneath. I just want to see the outside. The tools have just got to be easy. They've got to be accessible, and they've got to work within the whatever existing system is placed. I don't really need to know how this engine works. So for an operational model of telehealth to work, it's convenience. That's the major driver, right? So when I get into my car, I have a hybrid and I just want it to drive it, because as a physician, when I'm seeing the patient, I'm trying to connect and I'm trying to solve complex problems. I don't need to know, how the oil goes in and what other aspects internally are going on. And as we develop this operational model, we need actually more staff and to troubleshoot sort of the technology piece and support us. We need to figure out how to verbally consent and how to do dot phrases into text. And ideally, the EHR would be configured already for a physician to just jump in and to do telehealth. Documentation is always on our minds as well, because we need to be compliant. And what is the optimal way to set up the EHR? We know we need to have smart phrases. We also need to know that we need integration. We need the flow of all these remote vitals that are coming in from peripherals. We need, as certainly as I am an imager, high resolution pictures that go right in. In the future, maybe there'll be auto documentation of those images. Maybe we'll be using remote scribes. And of course, the interoperability is a recurring challenge. And we know as of next week, November 2nd, that the patients will be able to see our notes because that will be part of the law. Documentation has really shifted in this era because now the patients are assisting us in the physical exam. And this is a beautiful article that came from one of my friends, Katie Benziger, out in Washington State, on just sort of how you document a cardiovascular exam. And you have to involve the patient. They have to press on their abdomen. They have to show you their neck. They have to breathe. They have to actually move. And those are sort of the maneuvers that one has to figure out and how to do that well. This is a kiosk. Maybe down the road, we are actually going to have patients use peripherals that will allow us to document very directly. That is certainly the future. So in terms of billing, the physicians want to know, if I'm going to do a virtual exam and be compliant, I don't want to lose RVUs. So how's the proper way that I bill level 4 or 5? And we know that if you have a bricks and mortar, you're going to generate more billing codes because you can then send them for imaging and labs, et cetera. And the facility fee is not collected during telemedicine visits. And many of the commercial payers, while they're being supportive of telemedicine, they're not necessarily doing payment parity, and phone coverage sometimes is or is not covered by commercial payers. We know that billing is changing. Medicare, as of January 1st, is going to make it much easier for us. A physical exam is not going to be required for billing. You just need only to perform the physical exam when clinically appropriate. And now we'll be using more time-based billing. So those activities that you actually do the same day, which physicians do all the time: chart review, medical evaluation, looking at images, ordering tests, doing your documentation, coordinating care, making the phone calls, all of that is actually can be used for time-based billing. In the past, it was only face-to-face discussion. So that's a really big change. There was even a segment this morning on NPR on how physicians who are female spend more time with their patients, but in fact make less money. So there's going to be a gender equity piece that will be in this new billing changes as well. So not yet, but perhaps soon, we will have patients listing their iPhone as their primary care physician. So that being said, I would really like to thank Dr. Helen Burstin, who was quoted yesterday in the New York Times. Thank you for your advocacy and your bringing us together, all of us disparate groups. And I love this quote. Dr. Helen Burstin, Chief Executive of the Council of Medical Specialty Society, says, "There's ample precedent for the federal government to impose restrictions or create financial sweeteners for states to do so when public health is at stake." Thank you so much.
Oh, thank you so much, Ritu. That was lovely. And thank you for pointing that out. It's a difficult time, but it is a place where I think the House of Medicine's been pretty together on these issues, and anything we can do to keep it moving forward is what we need to do. So thank you. Delighted next to have Jorge come forward and talk to us more about perspectives on issues of equity in telehealth and digital health. So welcome.
All right, am I good to go here?
You're good.
Awesome. All right, well, thank you everyone for having me. As you've heard, I come from Brigham Women's Hospital. I'm a hospitalist and also do work in the technology equity space. Today we're going to be talking about striving for telehealth equity. And so, you know, I think as you've heard, a theme has come up over the past couple of talks, as we've all heard, you know, telehealth has been has had a great boon, but we've also seen significant developments in terms of inequities in terms of access to telehealth, specifically across different subgroups. And this is by no means an exhaustive list, but across racial and ethnic minorities, folks with lower SES, older populations, folks with limiting proficiency, patients with disabilities, patients living in rural areas. And this has sort of been part of our conversation that we've had. There've been, you know, I've written a little bit about, a lot of my colleagues have written a lot about how we're sort of developing this very digital world, but as it develops very quickly, we have this challenge of trying to ensure that we're delivering equitable care. So I like to start off just with sort of an initial discussion of, you know, what do we mean when we talk about telehealth equity. And really, when we talk about telehealth equity, is that everyone should have a fair and just opportunity to engage it. In this case, I say telemedicine for telehealth. And I sort of borrow this from some of our health equity definitions to make sure that patients, at least they have the opportunity to engage. They may choose not to, but they may choose to be able to engage either via phone or via video. And in this connection that you see here from the icon, it seems like a fairly simple connection to make. Just kind of, you know, connect the blue arrows there. But there's a lot that goes into that. And some of the things I'll highlight here today are really around technology access, technology literacy, important implementation considerations, which we've heard about a little bit already. Payment, I'll mention briefly. We're going to have a whole discussion on that, and then really ensuring that where telehealth falls in terms of the delivery of standard care. First, to start off, I think I'd just like to lay the groundwork that if we're really, you know, committing to this as a tool that we're going to deliver care, we really have to view technology access and literacy as a social determinant of health. And in order to do so, we really need to take steps, especially with technology access, to make sure we're engaging patients and meeting them where they are. So one of the first things I think about, especially when we think about, in the US at least, 21 million people don't have access to broadband, and that's probably an underestimate. Making sure that we're approached similar to other social determinants of health. There's a lot of structure around screening and referral. So do we have similar structures to provide that if we are screening patients? And I just read a paper yesterday about Dr. Aurora from University of Chicago looking at, they screened patients for access for literacy on their inpatient setting, and they found large gaps there. What's the next step that you do there? How do we refer them to subsidized internet, for example? How do we, and then more broadly, how do we engage at a policy level to deliver a universal broadband so that all patients have access to this? And I think there's opportunities there, driven by both Congress, but also by the FCC, to expand some of the things like their Lifeline programs, or engage internet service providers like Comcast and others to expand some of their subsidized internet tools. Similarly, in terms of device access, there's a big opportunity, I think, to collaborate with a lot of the work that's being done in the education space as it relates to addressing the homework gap. I know here in Boston, there was a big push to ensure that students were able to engage in remote learning, and a lot of students received devices. So can we sort of collaborate with that to make it more of kind of like a holistic or family approach, so that not only are we addressing challenges with education, but also challenges with telehealth access? The other big kind of like zooming out component is around really broadband infrastructure, to make sure as a country we're investing so that we're reaching some of those more challenging to reach areas, especially for our rural populations. The other big component to this is around telehealth infrastructure. So as we're sort of deploying these tools, as we heard from earlier talks, it takes a lot of work, a lot of implementation, a lot of funding to be able to bring some of this up and going. So how do we address that for some of our community health centers? The FCC had a great program, the $200 million program, where they invested in a lot of this tool, but how do we expand that in a more comprehensive way? And the last thing I'll mention in terms of technology access is really around looking at systemic ways the way we deliver internet access are being addressed. And I'd sort of like to bring up the concept of digital redlining, which really refers to the fact that some internet service providers may provide either lower speeds or higher cost, or both, in certain areas that are often served by the same populations that are struggling with access to technology and to telehealth. And how do we develop policies, or at least have conversations with the internet service providers, to make sure this is not the case? When we talk about technology literacy, I think there's a few opportunities here. One, I think, is really taking a step back and saying, we talk a lot about, the engaging patients and providing them the skills they need to meaningfully engage with telehealth. But is there a role to really look at the telehealth platforms that we're delivering, and is there usability such that we're able to make them a little bit more universally accessible to patients? One great sort of discussion is around limited English proficient patients. How many of these telehealth platforms that we're using are available in different languages, and how do those languages reflect the populations we're trying to engage, or the populations we're trying to deliver? And if there's a discrepancy there, obviously that's going to be a challenge. In terms of actually engaging patients, I think there's a big component around engaging community health workers, and I've chatted with a few community organizations who are trying to integrate this, or trying to integrate some sort of telehealth coordinator or digital health navigator as part of the way they deliver care. But that also requires kind of a human component, and also further funding and commitment from organizations to really fund these positions. And the other thing I'll mention is around collaborating with community organizations. Really, a lot of community organizations, libraries, some nonprofits have been working on the area of technology literacy for a while. So I think as healthcare organizations, there's really an opportunity to engage with them, so that we don't feel like we're reinventing the wheel here. This has been ongoing work, and so I think there's an opportunity to kind of clarify how those connections work, and maybe could be part of the referral process that I talked about earlier, where you screen someone, they screen that they lack access, you are able to refer them to a community organization to expand their access there. I think payment parity is so huge, and I know there's further discussion about this down the line. So I'll just say, I think in terms of equity, ensuring that that there's the payment parity across modalities, and I'll say across insurance as well. I think this distinction between in-person video and telephone, especially the video telephone piece, is so key to ensuring equity. As has been mentioned, a lot of our patients, even as we start developing a lot of these other solutions that I've talked about, will still require some component of telephone, and it creates a weird incentive or disincentive, I think, for organizations and for healthcare providers to say, well, I'm not going to be reimbursed as well for the telephone. So it sort of puts us in a weird way if we approach it that way. So I think there's some interesting work to be done there. In terms of implementation, I think there's important aspects here. I think one, at an organizational level, making sure that we're monitoring our telehealth use, not just are we using it or not, but who's using it and where are the gaps, and how can we really target our approaches to address those gaps, I think are sort of important, and borrows from some of the quality and safety work where we really, if you're not sort of measuring something, you really can't change it. And I think that applies here as well. I think that the implementation, the workflow piece has been mentioned a few times. I think from an equity standpoint, really making sure that we're making it very easy for everyone involved to engage in these tools. I think, again, one of the great examples I think about a lot is limited English proficient patients. That involves often an interpreter. And so how do we, is it easy to integrate a third party into our visits? Is that clearly defined how to do that? Because I think you'll create challenges and barriers in workflow that will quickly shift both patients and clinical staff away from telehealth if they're finding this is a big challenge in the limited time they have to see patients. The other thing is really engaging patients and family. There's a lot of literature looking at and reflecting on patient preference as being key to all of this uptake. So really engaging patients and family and making use of patient and family advisory councils as you're developing these tools and implementing these tools to make sure that we're sort of addressing the needs of patients and not making assumptions about what they may or may not want to use telehealth for. And to finish, I think that really focusing on delivering telehealth as part of standard care and not letting us make assumptions about who may benefit or was likely to use. So really focusing on, you can't tell a patient's likelihood of using telehealth by looking at them. So if we're really going to offer this as standard care, offering it to patients and having a conversation with them to say, this may or may not work for me, rather than making an assumption. There's some interesting data in the patient portal literature that looking at who was offered access to a patient portal or not. So I think there's some sort of evidence there that those similar types of approaches may be evident here. And I think the last thing I'll end in, at least personally for me, a lot of my work really focuses on health equity. And so here telehealth is not a panacea. Really, my goal to some extent is to extend these tools to all patients and looking at the quality and the cost and all the outcomes. But to some extent, my goal is not telehealth equity, it's really health equity. And so making sure that we're sort of applying the tool that we have to sort of this greater goal that is really the thing that we're trying to achieve. So with that, I'll stop. I'm happy to kind of keep chatting after in the Q&A, or if you want to reach out to me, feel free to do so. And thank you to everyone and Helen for the invitation. This has been super fun.
Oh, thank you so much, Jorge. That was extraordinary and exactly what I think clinicians really need to think about those issues front and center. The other thing we have to think about front and center is how it relates to spending costs and reimbursements. With that, I'm delighted to have Chad come forward and give us our final segment.
There we go. Sorry about that. Thanks so much for the invitation and for being able to present today. That was a great set of presentations we've heard so far. So I'll focus mine on telehealth and healthcare spending, and just a little bit about me. So I'm a clinician, a urologist who's been performing video visits since about 2016. I've been very passionate about this on the operations end, and I help our department expand the use of telehealth. And most relevant to this talk, I'm the director of the Telehealth Research Incubator at University of Michigan, where since we were funded about 2 years ago, we were studying this population level impact of telehealth on healthcare costs, quality, access, and the the patient experience. And the idea when the incubator was first funded 2 years ago was that we have individuals that are looking at telehealth and doing a lot of great work in that area, but bringing their voices together to accelerate this evidence is really important for policymaking. So I'll talk specifically on how telehealth may impact healthcare spending. And one thing I'll start off with saying is I think that it's pretty clear that telehealth is here to stay. Seema Verma, the head of Medicare, has voiced this publicly and often that telehealth has been transformative for the healthcare system, and we expect it to stay post public health emergency. But there's still a lot of policy issues that still remain, and many of your organizations are involved at high levels, talking to stakeholders about these policies, and specifically around the originating sites, which it's unbelievable, but it actually needs a legislative act to actually remove it, which is the originating site requirement, which is essentially that patients can't connect from home. And so there is bipartisan support for removal of this, and hopefully that moves forward. Do we continue coverage for audio only for telephone calls? Are we allowed to practice telehealth across state lines? And of course, what's the payment rate? So while there's not much debate about whether or not telehealth is going to be here in the future, there is a lot of debate about what its final shape and form is going to be. And along with that, there's also a lack of data too, a lack of population level data. This was a letter that was published in June where 30 bipartisan senators sent a letter to the United States Senate about the need to collect data on utilization, quality, and healthcare outcomes and spending to understand what will be the impact of telehealth. So a lot of unknowns, but what we do know is that the Congressional Budget Office for a very long time has scored telehealth bills very poorly. And so the total healthcare spending the changes in healthcare spending that will occur if Medicare and other payers expand telehealth broadly are going to depend on really two fundamental things. One is the payment rate. How much are the payments for these individual visits? And then number two is whether or not telehealth will be used as a substitute or if it will be used in addition to currently covered healthcare services. And so when you think about these two issues, it really helps to frame how telehealth can change healthcare spending. So I'm going to start with a framework to disentangle some of the impact that telehealth may have on healthcare costs. And so I'm a health services researcher, and anyone that works in health services research and focuses on cost knows that there is really three different perspectives when you think about cost. There's the patient perspective, there's the provider perspective, so the healthcare practice perspective, health system perspective, and then there's also the payer perspective. And the payer perspective, or society's cost, is what we're usually paying most attention to when we think about Medicare spending or total healthcare spending. And so for each one of these perspectives, there's an opportunity for telehealth to increase costs and also to decrease costs. And it really depends on those two fundamental factors of the payment rates and also whether it's used as a substitute or not. So for patients, costs can increase if there are more appointments with these lower barrier ways to access the health system. And also, many of you have probably read in the Wall Street Journal about co-payments coming back. So costs can increase for patients. And then costs can obviously decrease if there's no transportation costs or parking fees. So we did one study where we wanted to understand this, specifically looking at the concept of substitution versus expansion. And so this was led by one of our residents at University of Michigan, Juan. And the idea here is we looked at 600 visits that occurred virtually and 600 visits that occurred in-person visits. And this is using data prior to the pandemic. And what we wanted to do was look at these two similar types of visits and look at how many times did the patient have to come back within 30 days for something that was similar to what they were initially seen for. So this is called the 30-day revisit rate. And when we looked at the data, we found that there was two different types of revisits. So if they're coming back within 30 days for the same thing, they're either coming back because it was planned or if it was unplanned. It could be planned. When I see a patient for kidney stones and they have a very complex stone, I'll send them to one of my colleagues to treat that complex stone because he specializes in that area. That's a planned visit. But if I see a patient through telehealth and I wasn't able to get a full exam, and then I need to have them come back for a in-person visit, that would be considered an unplanned visit. So when we compared 600 video visits to clinic visits, what we found was there was no statistical difference in the rate of unplanned visits, which essentially hints at the fact, or this is some data that contributes to the idea that telehealth will be used as a substitute as opposed to an expansion of services. So from the provider level, there's two ways to think about it. Cost can increase if the technology is expensive or if you have subscription fees that are associated with the technology. And then cost can also decrease if you're doing enough virtual care where you may be able to replace staff. And so we wanted to look at the individual cost of a video visit versus an in-person visit from the provider's perspective, from the clinic's perspective to see if there was a cost savings. So this is a study that we did last year. It was led by David Portney, one of our medical students that's working with us. And essentially what we did was use this technique called time-driven activity-based costing, where you can actually look at the per unit cost of time for every step along the way of an in-person visit versus a video visit. And so we compared traditional clinic visits to physician-led video visits to physician-led, physician assistant-led video visits. And so we mapped out each step that the patient goes through, and then we assigned a cost associated with each step depending on who they were seeing during that time period. So if they were seeing an MA, an office staff, if they were actually having FaceTime with the physician, all of these have an associated labor cost. In this study, this was a simple study, so we didn't actually take into account some of the fixed costs that are associated with these visits, but we were primarily looking at the variable cost. And we were actually it was interesting for us to find that we didn't find large cost savings per visit for video visits versus physician-led video visits versus physician-led in-person visits. And in fact, when we were timing this out, we found that physicians were actually spending more time on video visits than they were in person. So the per unit cost was essentially the same. The costs were lower if you had the visits conducted by a physician-led physician assistant, but of course that because their labor costs are lower, the cost of the visit was lower that way. So the implication here was that video visits were not necessarily more efficient. If you had a 15-minute scheduled visit in person or video, you're spending about that much time for each one of these visits. And so the policy implication here is about payment parity. And so the provider cost savings can decrease, but it's unlikely unless the provider is performing enough of these visits to eliminate a fixed cost like a medical assistant, a clerical staff member, or rent. And if you look across the country where most health systems and practices are doing about 20% of their care virtually, I don't think that's likely to happen. And so then from the payer perspective, this is important as well. So costs can increase if there's new billable services, but it can also decrease if you're able to reduce adverse events like emergency room visits and urgent care visits by using a lower cost resource. And so this is a study that Kathy Lee led, who's one of the fellows that's working with us, an emergency room doctor, and she wanted to understand whether or not the use of telemedicine would prevent expensive emergency room and urgent care visits. And so she was specifically looking at upper respiratory symptoms. And when you look at across a spectrum of options that patients have, you can observe that's very low cost. And as you go up to telemedicine, to office visits, to urgent care and ER, the cost can go up. And so when you think about it in a very simple way, if someone has an upper respiratory infection and they choose telemedicine versus an in-person visit, they're going to have cost savings. But that's not the whole story. So if after that telemedicine visit, if that condition isn't necessarily resolved, and they could have a second telemedicine visit, they could have an in-person visit, or they can still go to urgent care and the ER. And so this was the study design that we set up to look at this important question. And what we found was we looked at the rate of secondary visits within 7 days after an upper respiratory infection. We compared in-person visits to virtual visits. And essentially what we found was two things. One was there was a difference in secondary visits within 7 days. Telemedicine visits led to more secondary visits, which is important. And these secondary visits often occurred in the office, or it was a second telemedicine visit. But I think one of the bigger punchlines of this paper was that it was still resolving about 90% of the initial complaints. So the secondary visits were less frequent than what we would initially hypothesize. So that at this point, I'd say that's some contribution to the literature, but there's still a lot unknown about this population level impact on healthcare spending, whether it's going to cause cost to increase or if it's going to cause cost to decrease. So I think there needs to be more population level data. I will comment, especially on new services like telephone calls and remote monitoring. I will comment on the fact on telemedicine and alternative payment models. And I think that this is so obvious that telehealth should be integrated into alternative payment models. But as long as we are still in a fee-for-service environment, if we were completely in an APM environment, that would be different. But as long as we're in a fee-for-service environment, I don't think putting telehealth only in alternative payment models is sufficient. In fact, next generation ACOs, bundled payment programs have actually had telehealth waivers since for a very long time. So the same deregulation that we have now existed in these alternative payment models for many years. And we all know that in February 2020, we still had less than 1% of Medicare patients in the country ever using telehealth. So it was insufficient to help telehealth grow at that point. So that's all I have to say on payment, but I am very excited to talk and answer any questions that are out there.
So much, Chad. That was great, and everybody can come back on camera. I've been told we can go a little bit long since after this is just our exhibit hall, and I think there's so much good stuff to discuss. So first, just thank you. I mean, it is remarkable the breadth of what you all covered in 30 to 40 minutes or so, and I guess just as a starting point, I'd love to see if you guys have any questions for each other, just because I think you all brought up so many interesting issues, and this is what you guys think about all day long.
I have a question for Jorge's for the healthcare workers. There was an interesting study that was out of Yale, Erica Spatz did, and that study used healthcare workers in the inner city population. But one of the questions that came up is, after the research study was done, then they didn't have access to those same healthcare workers to help them, navigate the system and figure out the technology. What do you think on a policy level that we should be thinking about in terms of, incorporating that kind of cost into the delivery of care for this underserved or this population?
Yeah, I mean, I think it's, and I'd love to also hear what Chad. I'm sure Chad has thoughts as well. I think that it's important. I mean, it's a lot. It's like a lot of other. I think a lot about limited English proficient patients. So like my mind often goes there. But I feel like it's similar to our challenge with interpreter services, right? I mean, they're such a critical part of the way we deliver care. Yeah, we know they're not reimbursed, and really the organizations are up to them to sort of have the funding for it. And I think we're probably approaching a similar kind of conundrum where really, if we're really committing to telehealth as a key tool, and we know that some of our patients struggle and they need that human touch to be able to engage, then we have to have sort of the funding or the reimbursement component to say, we're not just going to take someone who used to be, doing another job and just chunk out a little bit and try to have them go there. It's really having someone dedicated to that piece, and I think has sort of larger implications around the kind of reimbursement pieces. But I think that's what I say. I think it's just sort of a commitment and not sort of relying on organizations, because that's where you're going to have some of our, especially community health centers, may struggle with having that component. And some of the funding that came out of the FCC through their program, that will eventually no longer be there. It'll be used up. And so what are those community health centers supposed to do now that they've built up these programs and now you've taken away the funding? So I think it needs sort of a larger investment in the way we look at sort of paying for these services, is what I'd say.
Yeah, it's such an important question. I think one of the things that was raised this morning in our fireside chat with Lee and Michelle from CMS was Michelle made the point that it's going to be really important for them to be able to keep track of the safety and effectiveness of these visits as they make these decisions going forward. I know Chad indicated you've relied a lot on national trends from Epic, for example. Where else can we keep an eye, particularly on the telephone only visits, and be able to demonstrate that they are in fact effective and safe?
Yeah, no, I think that, there's a lot of national data sources, the Medicare, national Medicare data and other large commercial payer data that we can use to look at this. And I think that, we don't necessarily need, when I think about looking at population quality and the impact of telehealth, whether it's audio only or whether it's video, I think that we don't necessarily need to reinvent the wheel. I mean, there's so many quality measures that we have out there through the National Quality Forum, NCQA, and other organizations that are very well established and very well validated. So when we put this, when we're doing these studies at a population level, what we were essentially looking at is this exposure of telehealth and seeing the impact of telehealth on those established measures that are already out there. So if we, I'll give you one example of a study that we're looking at right now is whether or not practices that had telehealth, primary care practices that had telehealth during the pandemic saw lower rates of emergency room use and hospitalizations for these conditions that are called ambulatory sensitive conditions. Mm-hmm. And so that particular metric or outcome has been well established in a lot of other studies, and all we're doing is essentially layering this telemedicine exposure on top of it. And I think that would be the best way to look at this and monitor this long term. And I think that there's some hypotheses around how it could be better for care or it could be worse for care, but we really won't know until we have enough data to be able to draw that conclusion.
Right, but can we even track which visits, for example, and we've talked about this a lot on our tweet chats, a failure, like you started as a video visit, but maybe you then went to phone only because of, the lack of access to broadband. Are we tracking to be able to go back and figure out what was in fact telephone only, telephone plus video versus in real life?
Yeah, there's a couple ways to do it. And I'll just kind of talk about two ways that I know. So one is if you were looking in insurance claims, then you could look at the way that the bill was sent. Was it sent as a office visit with a modifier to indicate that it was video, or was it billed as like 99441 through 99443, which is the audio visit? So you can do it at that level. One study that we did recently was using institutional data, and we wanted to get a little bit of a tighter definition of what was an actual video visit. And so instead of using scheduled, we actually, in our electronic medical record, had a variable that said that a video visit or a video connection occurred. So even if the video visit was scheduled, but there was no video connection occurred, we'll assume that that was a failed visit and it occurred through audio. So I think the research community can find creative ways to sort of get at that, but it's a highly important question.
And they were pretty clear that they need that data. They need to see the effectiveness of that if we're going to keep the idea of, ultimately we'd love to have them all be full video visits, but in the interim, particularly with patients who can't get access, and keeping people safe, especially as the pandemic continues to unfortunately rage on, is going to be important. Ritu, you've thought a lot about effectiveness here. Any thoughts about how we can do this?
Well, I think you raise a very important point in terms of defining the variables that we're looking at, and certainly the failure rate, if we are calling it a failure, it sets it up. But how else? We know that there is blood pressure control data. We did a study here at Pitt looking at postpartum hypertension, and there was reduction in ER visits. There was a better control of their blood pressure, and certainly hypertension is perhaps the most, ubiquitous condition across America, and one that we need control over. And there is data to show that telehealth and those technologies improve outcomes. Of course, we need more of that, and that study was about 2,000 patients. Ideally, if we could collect data from multiple sources and different institutions, once that data piece gets regulated, that would be tremendous for us to conduct those studies, because we would have bigger numbers and we would be able to we'd have the power to detect the small differences. So looking forward to that as well.
Great.
I had a question for Aditi. During her talk, she mentioned like the training 150 or so clinicians over a short period of time. I wondered if you could speak a little bit more about what that was like in terms of, we talk a lot about patient tech literacy, sort of speaking on the other side, what some of the feedback was from clinicians, especially across different platforms and EHR. I wonder if you could just reflect on that a little bit more.
Sure. So, in general, right, most of the doctors had some experience in telemedicine. They just didn't do the acute care portion. They used Epic, which is a little bit different, right? You have a scheduled visit set up and somebody sets it up for you. So what we actually did is put everything in a centralized place, like everything I've ever created as far as workflows, processes. And then we made a video of how to do a visit for COVID, basically for dummies, like from A to Z. And so it was like every single aspect of it. So people could look at it and then like figure out like what to do. Most people figured it out just from that, right? We would have Zoom meetings just to make sure that people understood it, especially for those who might be working the next day. But most people were able to figure it out from that. And generally what we did is just be on call for people who may have had issues. It seems like a blur now, but I would say that that probably helped a lot. Just having people already understand the basics of telehealth and just having videos and modules already created so that they could access it, and then creating just the one for COVID itself. But yeah, it was just basically the fact that we had experience already.
Yeah, that makes perfect sense. It's such an interesting question of how we kind of take it from here. And I know we've talked on our tweet chats about how we've seen the overall volume of telehealth going down a bit. Any thoughts about how much of that is, and I know, Chad, you've talked with us, how much of this sort of uncertainty around what the continued payment models look like, or how much of it is just that it's just hard to get behavior change, particularly if there's not certainty about next steps?
I can certainly comment on that. Yeah, it has, since in-person care and as health systems and practices have become safer, it seems like the vast majority of the rebound has been in-person care and the drop in telehealth. I think we're leveling off at about 20%. And a lot of that has to do, at least from my operational experience, and Aditi can probably speak more to this, but it is really kind of resistance to change. It's very easy to walk into a room and to see a patient, and they're there. You don't necessarily know about their journey to get there, but it's very easy from a provider's standpoint to go from room to room to room. And so breaking that is really hard. I think early on, everyone was scared and wanted to do social distancing. So that was a strong motivation, but for some reason, we're less worried about that now, even though we really shouldn't be. And as a result, people are, favoring in-person care, both on the provider side and also on the patient side when they call in too. And I think that if that resistance to change, if you layer a disincentive by reducing payments for these, that is going to be the kind of final blow to drop it to 5 to 10% max.
Yeah, I worry about that too. And Ritu, I know in our discussions, you've also raised this interesting question of whether are in real life visits the gold standard for which we should be comparing. Any reflections on that? I think probably as we're starting to wrap up.
Well, certainly since 300 BC, that is the gold standard, right? Face to face. So
it goes way back. Is that Maimonides?
Right. So I think, it's very, very hard to break that. And the only way I see around that is to make this so easy. Like if we had it as easy to use as an iPhone, perhaps it would be so intuitive and so easy that a 2-year-old can do it. Then this is going to, from an operational point of view, doctors would be perhaps more willing, and then you could make the case and the patients would follow along as well. There are certain demographics that may have more inclination to doing televisits, including the younger population, the ones that are already very tech savvy, as opposed to, say, the older population. So it'll be interesting to see how that pans out. But I think, again, if we can operationalize and really streamline the workflows, that's going to be the real key to the culture change. Yeah.
So why don't we just do a quick round robin? Your last reflections of what you think will help us get telehealth to stick. Start with you, Aditi.
Oh man, so that's a complicated question. I think that, in general, it's just people understanding how to use it on both sides. Aside from all of the barriers that are there, just understanding what it can be used for. And almost related to what Ritu just said, if people, a lot of like the reason that some younger people can do this, if they're healthy, a lot of the healthcare, unfortunately, is transactional, right? They just need something done. They need a screening test. They need like just a checkup. They need a refill of a prescription for birth control, whatever it is. They understand that this is a real easy use case, and that may continue if we're able to expand it and understand how we can use it on the other side as those populations grow, and then apply to the ones that we have.
I agree. Jorge.
I think for me, giving it an equity lens, I think it really comes down to the sort of the basics that I talked about in terms of technology access, technology literacy, and really building that into the way we deliver care. I think that, we can we look back at whether it's the mobile app literature or the patient portal literature, and you find those kind of similar themes that come up. So I think really focusing on kind of those aspects of it will make sure that it sticks around longer, because I think beyond that we'll sort of end up where a lot of our other health technologies have ended up, where we sort of like they're sort of nice to haves rather than a central part of care.
Absolutely. Ritu.
I think we have to legislate data. Data is the new gold, and we need data to convince the insurance companies to pay for certain things, but yet there's no interoperability, and no one can convince somebody to take their hand out of the pot of gold. And until we have that legislated, this is not going to go very far.
Agree. Chad, the final word.
Wow, that's a lot of pressure. No, I think that ultimately, to keep telehealth around it, we have to have the mindset that it's a substitute for care. So it's effective for some things, it's not effective for some things. It works for some people, it doesn't work for some people. But if we have the overall mindset that it's a substitute for care and a natural extension of the care that we're providing, then if we think about that from a financial standpoint, from a policy standpoint, from an equity standpoint, I think that will help to keep telemedicine around for clinically appropriate things.
Great. Well, thank you so much. I know Julia's got one last slide to pop up here. Just want to thank you all for joining us today, and encourage any of our folks listening in to join us in the Industry Partner Hall during the break. But I'm really excited to package this session up. I think this would be a great one to share with our telemed folks. Maybe it's something we do for one of our Telemed Now tweet chats. We kind of put this up there and have people sort of reflect on it, because this was just really a masterclass on how to make this stick. Thank you all so much, and I'll see you on Twitter. Bye-bye.
Thank you.
Thank you.
Thank you.